wasn't here last week. Basically what we did was we decided to talk about just sort of case-based discussion about upper extremity fractures, mostly to deal with the lack of interaction that we've had over the past little while, and to help with resident education. The goal of this talk is really to see what other people think, and work through cases and work through ideas and concepts for proximal humerus fractures for this session. But over the next little while, we'll try to hit on a bunch of different upper extremity fractures. So I find that sometimes these get sort of forgotten in different talks. That people like to talk a lot about trauma. They like to talk about pelvis and acetabulum, and they like to talk about high energy femurs and tibias and plateaus and pilons. But oftentimes upper extremity can get a little bit forgotten. So the goal of this is to give a little bit more of a place for that. So maybe. Okay, so we'll record the sessions in case, I know some residents haven't been able to make it. They're in the OR, or others that have expressed to me that they've would be interested in the topic but weren't able to make the talk because either OTA or the hand society or other meetings had been happening at the same time. So what I did is we'll record these sessions. The links are in the chat, and I'll just paste them now so everybody has it. These are available so you can see anything that you may have missed last week. And that's it. Anything else I forgot, Mike or Milton?
No,
I don't think so. Sounds good.
All right, so why don't we get started? And I'm sure we'll have more people join on as time goes. So the first case is one of Mike's. So Mike Gardner at Stanford, for those of you who weren't here last week. So why don't you take us through this case, or at least get us involved, and we'll see what we can discuss about it.
Okay, so this is a 58-year-old female who tripped over a cat and landed on her outstretched left upper extremity. She's actually left-handed dominant, isolated injury, no previous history of arm or shoulder issues, and no neurovascular abnormalities, essentially an isolated injury. So, Milton, let me ask you, what would you tell this lady about how and likelihood of success for non-operative treatment? Any role?
give me 1 second. Can you,
What's that? You're muted now. You're muted.
I'm unmuted. Now, let me just, I cannot see the screen for some reason. Let me see.
Well, maybe I can talk a little bit about. So,
Yeah.
you know, I think while we're figuring out technical difficulties, I think, you know, this is a comminuted proximal humerus fracture. If we think, you know, just looking at this X-ray, to me, she's in a coaptation splint, which I think is fine. Her alignment looks good, and you know, I think it's reasonable to offer non-operative treatment for this patient as far as, you know, one of the treatment options. The question for me is then going to be, you know, what's the likelihood of this succeeding with good alignment? How much alignment are we, you know, willing to accept, or malalignment are we willing to accept? And how long is this, you know, how easy or hard is it to control a very proximal humeral shaft fracture with a functional bracing type of treatment? And so when I see this fracture, that's what I think of.
All right, so when she asks, like, all right, I'd like to avoid surgery, like, what does non-operative treatment mean? How are you going to do that? What do you tell her?
Yeah, so for me, you know, if a patient either has medical comorbidities that preclude us from doing, you know, operative fixation or any type of surgical treatment, non-operative treatment for her would be a functional bracing. So I put her in a splint like this, a coaptation splint for, you know, 10 days or so, let it kind of gel in a little bit, and then transition her over to Sarmiento type brace with an extension that goes proximal, that goes over the top of the shoulder to help maintain that alignment, or extend that over the top, and then put her in a sling to help control with maybe a little bit of gravity. So putting a slightly looser sling that would allow the elbow to drop down just a little bit, and then offer follow-ups with x-rays to ensure that the alignment is maintained over,
all right, and then how long do I
few
need to wear
weeks.
the brace for?
Yeah, so I think this is a it's challenging, but I think for me, what I typically tell people, it's about 6 weeks, and then I reevaluate with x-rays, and then I kind of see if it's starting to gel in a little bit, and if there's no gross motion or pain with range of motion at 6 weeks, then I think that they're going to make it. And then depending on how much callus, I usually transition them out of the brace. Now the difference with this patient is, this is a very proximal humerus fracture, so the likelihood of the brace really doing much is not as impactful as when it's a mid shaft or a humeral shaft type, lower down the diaphysis. So, I'd say probably put her in a sling for a few weeks with the splint, and then have her start range of motion the elbow, take an x-ray and see how it progresses. And if it's starting to heal, and at 6 weeks she comes back and I can, do some gentle range of motion without pain, and it looks like it's moving as one, then I'd probably transition her out of the Sarmiento.
Hey,
All
Jonah.
right, sweet. And then,
Listen,
so I'm going to
before
go through all that. What? What's that?
Can you hear me now?
Yeah.
So, I mean, if you
Let me hold
look
on.
at your case, huh?
Let me just I'll get to what I'll get to you in just one sec.
Oh.
Well, I was just
No, I'm just saying, let me finish with Jonah. So Jonah, just on this, kind of on the same line, so I go through all this, what's the chance that that's going to work? You tell patients.
I think for this, we know from the literature, the classic sort of Sarmiento literature, it's probably fairly high, probably not as high as the older literature suggests. So, some literature had said up to 95% success rate. I think it's probably lower. I don't have an exact number based on science for this type of fracture, because I think this is a little bit different. But I'd say, probably 50% chance that it heals with very good alignment, and then anywhere from up to 75% chance that it heals well, but with unpredictable alignment.
All right, good. That was a good discussion points. All right, Milton. So I don't know if you heard most of kind of the things he was talking about, but any different thoughts for like non-op methods and success rates?
no. I was actually going to ask him, how long does he really, like, on average, keep these Sarmiento braces on for his patients? Because it's very rare that I have one on for less than 10 to 12 weeks, right? Like, for most people, even the ones who are doing great, unless they're crazy head injury patient with a bunch of bone formation, I feel like it ends up, they need a little bit more protection for longer than 6 weeks.
Yeah. So that's an interesting point, because only because I do it a little differently, and so it's always interesting when it's controversial. But so I've generally found that if it's gonna work eventually, then by 6 weeks they're pretty solid feeling on exam, and they don't have any pain, but their x-ray looks horrible, like there's no bridging callus evident, but it's solid, and so the x-ray lags behind. So at that time point, I usually am just kind of feeling bad for them, and I'm like, look, if you can avoid torquing your arm, protect it in a sling when you're outside, it's okay to get it out of the brace at 6 weeks. Like, I don't think it needs to be bridging callus to take the brace off for me anyway. Jonah, how about you? How do you manage that brace?
Yeah, I totally agree. I've gone almost exclusively to the 6 week, 7 week, period. That if there's motion or pain with like gross motion, when we examine them at 6 weeks, then I don't think it's going to make it, and so then I'll transition them to operative treatment. I think I am like you. I start to take the brace off at 6 weeks. I tell them, especially one like this where I actually don't think the brace is doing as much as it does when it's lower down. I think I would transition them out at six weeks. They say start to come out of it, and then usually by 8 to 10 weeks they're completely out of it.
Yeah, so that's the next issue. I think like most of these things we're talking about apply to kind of mid-diaphyseal, whatever, whether simple or comminuted. But so Milton, anything about this one that you think would behave differently than a kind of more standard mid-diaphyseal fracture?
Yeah, I think the big things I worry about are my rotator cuff attachments and whether the head's going to fall into varus or do something different. Obviously as you get a little bit more distal, you get a lot more control with your brace. So like Jonah said, even the over-the-shoulder brace doesn't really control it very well because it doesn't come high enough on the medial side of the arm. And then additionally, I've seen it. I feel like that over-shoulder brace caused them to have a little bit more stiffness in the shoulder in the long run. So for them, that's kind of one of the other things that I tend to kind of lean in the more aggressive treatment range for these kind of injuries.
Yeah, interesting. Yeah, so I agree. So to me, when I saw this lady, the proximal extension's obviously concerning. Now, the more common proximal extension pattern, is this like long oblique that's just distal to the deltoid tuberosity, and those I would say there's only 1 or 2 series I'm aware of, but non-union rates are like 40%. You've got such a long lever arm for the deltoid, and it's hard to brace, like you guys have been saying about this one. But this is a little different. This is just comminution that kind of goes up to the surgical neck.
Yeah.
So talk to this lady, and actually, I guess I was less optimistic about non-operative than you guys, maybe a little bit. I really don't think a brace would control this too well and whatever. So admittedly a little bit pushed her to this would, I think, be better for your arm to have this fixed to get back to earlier function.
And I mean, I'll agree. I'll agree that to me, I see this fracture. I will probably recommend people to, active people to get surgery, just because I think that it's a lot harder to hold with any type of bracing. So I'm exactly like you. I will offer them surgery if they're medically, able to have it, and say, these are the options. Basically, if I fix it, I'll let you range of motion. Start range of motion probably, the next day after surgery, and we'll get you moving and up. Versus you'll be 6 weeks in the sling and the brace, and so usually younger, more active patients tend to take the surgery. That's been my experience. Whether or not that's the right answer, I don't know, as far as limiting potential complications. But I think if you explain to the patient, and they can make a decision at that point.
Yeah, good points. Bill, anything else?
No, I agree with Jonah. I agree with both of you. I would push this one in the direction towards surgery. My conversation would skew it in that direction as well.
Yeah. Okay, good. So now she decided she wants to have it fixed. So what do you think maybe your like 1, 2, and 3 surgical plans might be, Jonah?
Yeah, so just looking at this, I know you guys don't always agree with me, but I usually end up getting CT scans for the proximal extent, just to see if there's a tuberosity fracture, just to see.
Oh, I thought you were going to say reverse, that we don't always agree with you.
No, we don't.
You never agree with me on those.
A long reverse is the right answer for her.
Yeah, I mean, when you have one hammer, everything looks like a nail. No,
so CT scan.
I get a CT to see the tuberosity involvement, and then my general pattern for proximal humerus or humeral shaft fractures that extend up is, if it needs fixation into the humeral head, then I'm doing an extended anterolateral with a plate. And my go-to plate is sort of a proximal humerus, long proximal humerus plate. And I'll do that either as a bridging concept if I don't think I can get good cortical reads on the metaphyseal fragments. Like here, I can see just from the X-ray, looks like there's 3 large, maybe 4 large fragments. And if I can do that, I'll do a bridging concept. If I think that those pieces look like they'll lag together, and they have some sort of cortical reads, like these ones are nice long, pieces. I think one thing I like doing is clicking them in and putting in, mini fragment screws. So I'd probably start with the large piece and put it down to the intact shaft distally, and then work my way back up. Now, the problem with slightly older, now 58 is not very old, but she may have some osteoporosis. Getting those to hold can be difficult. And so that's when, using mini fragment plates can be an option to help hold that temporarily while I put a larger plate on the outside. And then, another option would be a nail, although it isn't my go-to, just because as a 50% shoulder surgeon, 50% trauma surgeon, I tend to respect the rotator cuff maybe a little bit more, or fear it, I guess. And so I wouldn't go to a nail right away, but that would be an option as well.
All right, cool. Milton?
Yeah, I think for this one, just with the CT scan, we'll have more data. But looking at the injury, looking at the fracture fragments, it looks like something that'll come together with lag screws and kind of a large proximal humeral locking plate as a neutralization plate. Often for those lag screws, I will use, like Jonah was saying, I will use a mini fragment. So whether it's a 2-4 straight plate or something or like a 2-7 recon, something that's long enough where I can get lags through that plate, but it gives me a little bit more rotational control and prevents me from, having to deal with countersinking little mini frag screws in someone who may not have great cortices. So those act like a washer so that I have a little bit more support for my lag screws.
Nice.
And then, I agree with Joe. I think for this injury, and if there was a little bit more comminution, if I was going to nail a humerus, this is kind of right along the line of something that's not an unreasonable humerus to nail. So if somebody has multiple medical problems, you're trying to do a limited approach, someone has very, 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 very high cosmetic complaints or things like that, this may be the nail type patient, just because that there's a bunch of small fragments. You're not, you're going to bridge all of that stuff. You provide you're providing good bridging, and it should allow this to heal. You're not worried about it distracting as much at the fracture site like you would with a transverse injury.
Yeah, good. Okay, so yeah, I agreed, with most of that at the time. I thought non-op wouldn't be good. I agree, and in talking to people, I probably nail more than most, although still really not much. But I agree, this is like a reasonable one too. But I decided not to do that. So I thought a plate kind of construct would be the best. I didn't get a CT scan because I actually used the X-rays to look at these diaphyseal fracture fragments. And so, I guess the kind of point of showing this case, just as a little bit of a technique option, is, these. So actually, first, one thing, I think this is a hard pattern to bridge plate in the humerus.
Yes.
It's kind of, it's like technically comminuted, but there are 3 dominant fragments, and unlike in the femur or, another weight-bearing area, you just don't get the same bridge effect, I don't think. So, and then lagging them independently, the thing I've kind of just struggled with is, you've got kind of multiple barrel staves, and you're trying to edge thin cortices, and there's no far side to lag into. It just can be very hard. So you can go to the next. So this is a good example. These happen to be 2 cases I used fibulas from last week and this week. But this is another good, I think, use. So we put a fibula in. This is kind of this is a little bit of a different application than we looked at last time, but it's just kind of a metadiaphyseal template. So you can go, and this just goes all the way down. And then you basically just can tack these shells back to the fibula. And again, the fibula just fits pretty well in the humeral diaphysis most of the time, particularly if you burr off the spine of it. And so it ends up being very technically easy, as opposed to trying to get these edge reductions and tricky lag screws. So anyway, you can go. And then, distally, just as a reminder, as I'm sure you all know, as this the proximal humerus plate that goes laterally but is long, depending how distal it goes, you need to remember about the radial nerve. And
Yep.
the knee jerk is sometimes to kind of perk or whatever that screw, but it can be, this is a little shy of where it can be in the danger zone, but still really need to think about where that screw is relative, because that's right around where the radial nerve crosses laterally. So
I think that's an excellent point. I tell residents every time that it's there, and they often don't believe me, and then we go and dissect it, and then you see. So I think that's maybe the 10-hole plate.
Yep.
Right? So anything 10-hole and above, depending on anatomic variance, you'll see that nerve is right there. So you're right, and I go and dissect it out, and I find it, and you can really see it's right at the end of that plate. It's really easy to think about maybe drilling and having the soft tissue get dragged underneath. So I think that's a good point. And going back to one of the questions in the group, in the chat from Dr. Giffens is, do we do anything to confirm the radial nerve isn't in the fracture if you're gonna nail this, right? So Mike, you said you nail these more than most. What do you do? Do you go and make a mini open, or do
actually,
you just...
yeah, that's a good question. So interestingly, the patterns that I've been most kind of satisfied with nailing is actually the mid-shaft transverse. And it's interesting, if you do them within a week or so, the manual manipulation, you can get them interdigitated a lot easier than you are used to, like when you nail a femur or a tibia. So you can just kind of, and so when you get it keyed in, and you can see very clearly on fluoro, you don't need to worry about it. So if that happens, I don't do a mini open to find it. If I can't get it reduced, I'll do a mini open. But so when you nail kind of a long segment of comminution, yeah, you absolutely need to make sure you don't ream through that. So we'll be very careful just to push slowly past. We kind of do that in the femur, but it's much more critically important here to just gently push that slowly until you get into the distal segment. You don't need to ream much in humeral nails, but so I love the rule of thumb about the 10-hole plate or longer is distal. And then the rule of thumb I kind of use for humeral nailing is you try to get to a 9. I don't know, the system I use has 7.5 and 9, and 7.5 is much weaker.
Yep.
And so to get to a 9, usually you don't have to ream much, but you can certainly injure things by reaming. So that's a good point.
I actually like this technique here, Mike, for those ones with a lot of comminution at that metaphyseal region. This is kind of my go-to. Rather than trying to do a plate or anything like that, I'll use the fibula as well, just as kind of cortical reconstitution. Yeah. And then that's where I'm getting, because I feel like just that lever arm you have with humeral bone, I worry that you're going to have too much motion and you may fail just because, a lot of times patients don't have great bone in their head anyways.
Yeah, and then, right, so to your point, not only does it make the reduction easier, but it really is just rock stable. And Bob Dunbar makes a good point that, you see this pattern where if there's this medial, kind of distal to the calcar, but medial cortical piece with the pec that's pulled, hard to lag, and lags are often weak. And so that's another good time to get a really bomb lag screw through that fragment into a fibula.
Yeah. Exactly.
All right, so some take homes are that, the extended anterolateral can be very safe. I think we think about axillary nerve all the time, but think about radial nerve distally. Go find it. It's there, brachioradialis, brachialis. You find it, you can tag it with a vessel loop, and then it's protected. It's fine. And then just make sure that you watch the plate. And I harp on this all the time, but I've seen people put the plate on the nerve. Just make sure that you can see the plate is on bone before you put a screw down there. And if it's on there, then you're fine. And then the IM fibula is really good. Yeah, sorry?
I was just saying, I find it every time, even if I'm using kind of an 8-hole plate, I'll extend and just go look at it, just so everybody can see it. Cause you can see how tight it wraps around sometimes, directly along the humerus, right as it starts to widen.
Yeah. And it's classic, right? Sliding it down.
Let me ask you guys another question about comminuted humeral shaft fractures. Either of you guys have any experience, or anybody else on this call for that matter, Bob or Rez or Julius or Mike, perk anterior humeral plating, speaking of kind of nerves at risk? Anybody? So there's a randomized trial. There's a lot of literature on it. I actually don't have much experience, but it's certainly a kind of an interesting technique and makes a lot of sense.
I haven't.
No.
My partner has done a couple.
I
No,
like it.
he hasn't had any radial nerve palsies with him. We don't have any long-term kind of healing.
Yeah, Kevin Tetzworth has he talks about it all the time. Julius, is that you?
Yeah, I mean, if you don't want to nail something and you want to be in bridge mode and you want to have the biologic benefits of not opening it, then I like it. You know, there's good literature support. If you're not doing it a lot, you know, there's a little bit of a leap of faith because you don't see the nerve directly. You make sure the nerve's not under the plate distally, but you're not going in there and dissecting it, and it makes a lot of sense in a way to apply a bridge implant. So, you know, I haven't done a ton. I've probably done a handful, but I think it's a nice option, especially in a big muscular arm where you end up digging a pretty deep hole if you in fact are going to do an open anterolateral approach.
Yeah, some of the x-rays they show are kind of the extreme bridge plate. You see these like 14-hole plates with like 2 screws on each end. But it seems to work. Like the fixation failure is really not really even been reported, but cool.
Yeah, I think it makes sense. I think, you know, the question is that better or worse than a nail? I don't know. And if you're going to put it all the way up into the head, then I don't see how you can really do much of that from the front without causing impingement. But maybe there's a way that they can do it. So
yeah,
anyhow.
I think
all right.
I think, in my opinion, it's better than a nail for bridging the shaft.
Okay. Good. So
Level
we'll have time
5.
to talk about that next week. Hopefully, maybe Julius, you can show us one of your bridging anterior platings. Milton, this is your case.
Yeah. So this is a 96-year-old woman who had a slip and fall at home, presented with severe pain. This was a ground level fall. She lives independently. She occasionally uses a cane for just some lower extremity arthritis. And she presented with this injury. So why don't you, Jonah, why don't you tell us what you see, tell us what your thoughts are.
Yeah, I mean, you know, the number one thing besides obvious fracture on the x-ray, the number one thing that comes up for me looking at this slide is the 96 right in the top left.
Yep.
You know, we think about proximal humerus fractures in old patients, they start to be, you know, decreasing rate of return on the, you know, fixation or treatment. So thinking about them, that's the one thing I see. And then the second thing is active. And so for me, patients that are still, you know, we have these patients getting older and older that are living by themselves or living, you know, in an assisted facility, but semi, you know, autonomous and still doing lots of things and have a lot of pain and want to get back to doing some sort of function. I think, you know, while there's a large amount of the literature and discussion recently that's been focused on non-operative treatment, I still think it's worth asking the question if, you know, non-operative treatment is adequate for these patients. And so if I look at the x-ray, obviously this is like a 4-part fracture. It's not really dislocated, but when the articular segment is looking the wrong way, it's usually a bad sign for this to do well as far as function, or at least that's what I've found. And so when when I see x-rays like this to me is a replacement in an older patient, and the type of replacement is a reverse. That's basically I would do nothing or a reverse based on the patient's medical comorbidities.
Yeah, I mean, I would consider fixing it. I mean, this is one that I think a CT scan would help because.
Whoa, CT scan.
Well, or an axillary view. I mean, either
Okay.
way, either get a complete radiograph series or a CT. No, but I mean, so, you know, these valgus ones, so this head may either be kind of impacted on the shaft and really be kind of eggshelled, but sometimes it can be kind of rolled off the back, and so you don't really have a sense of how much bone is left in the head. I mean, it's going to be a thin head. She's 96 years old, but you know, you prop it up and you can anchor the medial hinge. She's got one of these short hinges that Hertel you know, calculated, but you'll be able to dock that pretty well, and then you can hold these heads up. You know, you can fill it up with whatever. When you reposition it and pull the tuberosity back down, there's going to be a hole, and there's a lot of good ways to fill that hole up and rest the head on it. And so it's doable. I mean,
so question then, what's the advantage of fixing versus replacing in a 96-year-old?
Yeah, I mean, you know, I think the complications of reverse for a fracture are devastating when they happen, and that's mainly instability and infection. And so, you avoid these things, which essentially, would leave her with a flail shoulder or whatever, if that happens. And so, yeah, so you fix her and you retain her own bone, you get her moving right away. I'm not saying I definitely do that. It would depend in talking to her, but for me, it wouldn't be just reverse versus non-op.
I think what's interesting is that we look at, we always talk about complication rate because of some of the first papers that came out for reverses in the US came out of Boston, so JP Warner's group, and their complication rate was like 25 to 40%. And so obviously when you have complication rate that high, there's a high learning curve, you might, it's associated with a lot of problems. But I think if you look at the proximal humerus fixation, a couple of more recent studies have come out, one out of Edinburgh with the Robinson group, and looking at what complication rate for operative fixation of these fractures for all comers, forget 96-year-olds, and you're looking at anywhere from 20 to 40% as well. So, and this obviously includes smaller complications, but I think, the complication rate, if for anything, if you can get your personal complication rate down, then it's probably acceptable to do either or. The only thing is what the rate of revision would be for her, what the rate of head collapse and potential, hardware failure or prominent screws would be, where she would need more surgery. And I think to me, that's really the one question.
So that's one good point. So I would use like calcium phosphate cement personally, but then, yeah, you absolutely, even with that, it can settle a little bit. In fact, I would say most settle a little without frank fixation failure. And so you need to you can't put the screws up to close to the subchondral bone. And you don't need to when they're kind of rebarred in cement, but if you do put them close, yeah, exactly. So
it's the perfect problem, right? You have a thin headpiece, so you want screws that are really going close to the joint, but because you have a thin headpiece, that it's probably going to settle, so those screws end up perforating a little bit. So to me, those are the ones that are really hard when that head fragment is really, really thin for fixing.
Hey guys, can I ask a question?
Yeah, I see Dave Beret.
Hey, is this a good one if you're going to fix this, to go ahead and just use PMMA? Minimize any chance of settling. Do you burn any bridges? Does it compromise anything? I understand that, you're going to maybe not technically heal, but you probably will have enough, fibrous osseous healing to account for that. And then just eliminate any settling potential. I think what you don't want is this lady to go to the operating room again for an iatrogenic type problem.
So Dave, let me ask, the fact you are proposing that, have you found that like a calcium phosphate cement lacks some like compressive or some ability to provide a scaffold that would be better with PMMA?
No, I think what I've noticed is that unless you have really good handling characteristics, I can handle the PMMA a little bit better. Mm-hmm. And what you guys just mentioned about, you got to be cautious running screws into this fragment because there's going to be so little of it left. You're going to be right next to the joint surface. So I know that PMMA is not going to settle.
Yeah.
Okay. And I know I can fill it because of the consistency I can get it to, and then I can use it. Just more familiar handling for me.
That's a good point. Yeah, it's interesting.
And there's some literature to support that with the PMMA, certainly in the hip and now in the proximal humerus, people placing PMMA through the screw. So Milton, why don't you tell us what you did?
Yeah, no, I actually had a pretty important, that whole conversation with her. I talked about kind of the idea of fixing it, what it would entail, what it would allow her to do if everything went perfect. And those same complication risks, like the idea that she could have settling, she could have screws which require to come out. There's hardware that could be irritating for her, or kind of causing impingement and things like that. And then I talked to her about a replacement as well, and with the idea that that's going to be your end stop. And I think that was the thing that for her kind of pushed her in the direction of kind of replacement. The idea that the goal was one surgery, barring the fact that if you do have complications, that could lead to more surgeries. But, that was the plan and that was the goal. So
there's a question about an expandable cage. And so I've actually gone to using that implant a fair bit, I would say, particularly in older people. And I push the limits with age. Again, it's not obviously all about age, but, a guy, an 89-year-old guy with a kind of a typical, not as actually severe as this valve, but a valgus injury pattern, fixed and kind of worked okay. So I think similarly, an expandable cage is reasonable. The few I've done in the extreme elderly, similar to screws, do seem to settle a little bit. So I guess, with that implant, you can put screws through the cage into the head. And so similarly, you want to back the screws off a little bit.
Yeah, and the one thing I'll say is I've done one in a younger patient with the exact same pattern with the articular segment facing lateral. And I put it actually worked really, really well, but she went on to AVN. So the head, it stayed in the same place, but it just collapsed. And it was a lot more challenging to take out, to do a revision to a total shoulder. So I think it works really, really well in those cases. It just it maybe works too well sometimes. But yeah, so here's Milton's 3-year follow-up. So that looks pretty good. So
does that look good? I don't even know what we're looking at here.
Well, he's got no notching. He's got no loosening.
Okay.
Yeah.
Okay.
So maybe just for the residents, a quick couple of things, just key points that I tend to do because I do a fair amount of these for fractures. I put them in beach chair position. Obviously, the more you sit them up, the better you can see, the less blood pooling and everything, but the higher risk. So have a good discussion with the anesthesiologist as how much you're willing to run them, low pressure, how high up you can sit them. Think about sitting them up in multiple time periods. I bring the patient all the way over to the side of the bed, make sure the scapula is supported as opposed to an arthroscopy, which we're used to doing in beach chair. You put them over, you want the shoulder free. For these ones, I like having something to support the shoulder to put retractors. And then I tilt the head. You can see this arrow here. That's where your reaming and, for your canal is going to be. So oftentimes the head is in the way. So just carefully make sure their head is out of the way. And then for the approach, I tend to do standard deltopectoral, but I do release about 1 centimeter of the biceps, the pectoralis. I do a tenotomy or a tenodesis, and then I'll use these brown retractors. And I personally release the coracoacromial ligament in every one of these. I find that it gives you a really good view. And so a couple of take home points for the reverse, and maybe we can talk about this, but what's the minimum age for these now? I was part of a group where we started looking for the ASCS at 55 and over for doing a reverse for a proximal humerus fracture 4-part as the initial treatment, and randomizing them between reverse and non-operative. So I think people have been pushing the indications. I don't know if that's a good idea. And then obviously maximum age, I think, what's the oldest? This is a 96-year-old. I've personally done one in a 98-year-old, I think. What do you guys think? Milton, what's the youngest you'd be willing to put one in?
I think the youngest I'd be willing to put one in is the youngest I've put one in is a 65-year-old who has a head split with Parkinson's, like early onset Parkinson's. There has to be some real extenuating circumstances for me to put one in somebody under 75. And his was like a real true multiple head split. And he, from a Parkinson's standpoint, he had, he was pretty severe.
That increases risk for instability?
I don't know. And that's the question. I think it may increase his risk of instability, but it also, I think it also, the amount of function that he needs, he doesn't raise his hand over his shoulder anymore. He keeps his hand around by his sides. So that was kind of my thought process in that. But
okay, so maybe this will transition. So I snuck an extra case in here so when you guys weren't looking. So I put case 6.5 in here. So this is similar to what you're describing, right? We can kind of work through this quickly, but this is a 51-year-old. This is a manual labor, heavy, worker who had a motorcycle crash. He had bilateral acetabular fractures, was in the ICU for about a week. And so just for Dr. Gardner to be happy, I put in an axillary view here. And you can see there's a head split. This was initially dislocated and then relocated. But it took about a week to get clear. And because, you know, he's one of my patients, obviously he got a CT scan as well.
Yeah.
And so this is maybe similar to what you're talking about, Milton, as far as pattern goes. You know, this is a head split 4-part with bad, you know, pieces. And, but he's 51 and he's a manual laborer. So what do you think for this guy? Do we do reverse for this guy? Do we do fix? Mike, what do you think? Fix, replace?
Yeah, I mean, I think you fix this for sure. You know, I need to study the CT scan, but you know, there's head splits and then there's head splits. And at first glance, this to me looks like it's this lesser tuberosity fragment, not the tuberosity itself, but it's got groove, some greater, and then some articular surface. And this has just a little more articular surface than most. So it's probably just an anterior fragment that contains maybe a third of his head. And that the implications of that is that you are able to mobilize that piece a lot easier. And it's a bigger piece. So you're able to get a good articular reduction on this. Andy Chu wrote up a pretty cool technique in JOT, I don't know, a few months ago. Just kind of a peel like you would do, I think, for a reverse and externally rotating, but to put back together the articular surface, which is kind of cool. And then so you piece it back together. Anyway.
Yeah, that was reviewed by a very very well-known surgeon. That was
oh yeah, was that you?
Yeah. So you're right. So just to show you, so in the CT, you're right. That is a head split. That's that classic sort of coronal split, or it's split in the coronal plane. But there's also another piece back here. So when you actually go in, it's like in about three large pieces and then several smaller pieces, and then it's a 4-part. So it's really, and now you're at 1 week out.
Yeah.
Does that change your management?
Yeah, I don't know. 51 laborer, probably not a good arthroplasty candidate, or he's got to get a new job.
I agree with Mike. I'd probably still push towards trying to fix this one.
You try to fix, and then if it goes to, you know, the salvage for a well-reduced proximal humerus that goes on to AVN or, you know, AVN mainly, or osteoarthritis, I guess, is a lot more predictable than I think in an acute fracture or in a malunited fracture. So I think you do a good job fixing it and give it a shot and treat the sequelae from there down the line.
If I'm gonna, can I weigh in here for a second? Because I completely agree with Michael. I think that calling the lesser tuberosity that has some head on it is, I think, very different. I don't count that as like a head splitter, but even still, if I was to take care of this guy, I would really work on getting this reduced and really making sure that I got the tuberosities reduced. And the idea is that when his head goes downhill, that if I've given him good anatomically and healed anatomically reduced tuberosities, I think it would give the arthroplasty options more predictability. And then maybe this guy then gets more of a conventional shoulder, and then maybe 10 years down the road, he gets a reverse if that's the way it goes. But I think each step of the way, he should be able to have good function. I worry about a reverse or something, arthroplasty in a 51-year-old laborer that's banged up like this. What's he going to be like in 5 years or 10 years? He's still a young man, and he's maybe got a shoulder now that's burned a bridge. So just for me, I think that at this age, I would fix this, but really pay attention to the reason I'm fixing it is to give him good longevity, but to make his next operation more predictable, which is likely to be an arthroplasty.
Can I say something?
Sure.
And this just got brought up in chat. I mean, this guy is the candidate for a Hemi, right? This is the guy that you get in there and it kind of crumbles and falls apart on you while you're in there. This is the guy that Hemi is still the market for. So
yes, so I can show you what I did. So there you go.
Speaking of which,
so I think Hemi for me is a very rare thing as opposed to, let's say, 10, 15 years ago when it was much more common. But I think I go to reverse almost exclusively, except in this specific type of patient. I don't disagree with what Mike and Dave said. I think fixing it, if you can fix it, and getting the tuberosities down actually works really well. And you may have to come back and do more surgery later on, but at least you're setting everything up. The anatomy is nice and everything's good. The only thing I'll say is, to Mike's point about the Andy Chu paper, is if you're going to do a peel, you only have like so many ways or so many times you can go into through the subscap. And so if you have to do that peel, I probably would rather do a hemi if I think that it's going to fail, you know, if it has a high risk of failing, right? So it's kind of a trade-off. You're doing the peel, you get a better reduction, so maybe you have less chance of it failing. But if it does fail, then now you've sort of made your second procedure a little bit more difficult for function. So I kept these images because you can see the first image I did on the left is actually the initial head. I just matched it 1-to-1 on the back table, and I thought it was too big. So we made it actually smaller, but it's a little bit thicker, and we sunk the stem down. And then I provisionally reduced the greater tuberosity. And then something that I've gone to doing since over the past few years is actually, once the definitive stem is in, is reducing the tuberosity. And actually, if it's a large enough piece, I plate it, because I think part of the issue as to why these don't heal is one, they're over tight. So, you know, people tie them all the way down to the shaft or to the stem, and then over reduce them, putting a lot of tension on the cuff, and then it disappears, or there's not enough stability. So I think I've now gone to sort of a hybrid construct, like we talked about last week, doing a plate with some screws and then also putting suture in. And so yeah, so for me, you know, I think hemis still have a place. They're rare. I don't do it very often. I do maybe 2 a year, but I do them when they're younger, high demand. I also do them when they're older, lower demand, but I think that the complications with a reverse might be too high with regards to instability. So for instance, that Milton patient with the Parkinson's, so I will do a hemi, and I've gone to plating the tuberosities when that happens. And then for the residents, knowing how to position the head, I think it's you know, there's an article out there that says about 5.6 centimeters from the top of the pec tendon. So one thing that I do if I think I'm going to do a hemi is I don't release the pec tendon during my deltoid pec, so I have a good measurement for that. Anybody other opinions?
Are you doing the same thing with the tuberosities for your reverses at all, or you just suture fixation only and let them go where they go?
So I found that in the older patients, the tuberosities tend to be not as big, so I don't have that same option for the plate. If they do, I will do it occasionally, but otherwise I tend to just fix it with the suture. I do a very similar suture pattern than what I usually do for my lesser tuberosity osteotomies to go in. So I do 3 or 4 large bore number 5 non-resorbable suture, and then tie them down both horizontally and vertically, and then that's been pretty reliable for me.
Jonah, when you're putting the plate on the tuberosity, are you also suturing it down?
Yep, combo. So doing that as a All right. So I think hemi, you know, take home is really a hemi still do have a place, maybe, but you have to have the right indication. All right. So here's another one of my cases. Sorry to crowd them back to back, but this is a 79-year-old. So she's slightly younger than Milton's patient, but she lives in assisted living, and she had this ground level fall. This is an isolated injury, and so, you know, we think isolated, this looks, you know, pretty reasonable. But if I look at that X-ray, Milton, anything that worries you off the bat?
I mean, it looks like you can see a little something along the shaft as well.
Yeah, so she's got a little something along the shaft there.
Yeah, so, you know, I mean, that the proximal humerus component looks almost equivalent to the one that we just showed. You can tell it looks like she has pretty terrible bone. You also know that she's not that independent if she lives in an assisted living. So functionally, you know, I'd be interested to know what kind of shoulder function she had beforehand.
Yeah. She likes to knit and do things like that, but she's not an avid basketball player, so you won't have to worry for her on the court.
Is that stuck under her glenoid, or is that just?
Yeah, it's sort of like it's right on the glenoid. It's sort of impinging on it, but it's not frankly dislocated. It's sort of dislocated. Hey, Mike, looking at this X-ray, this looks to me. I'll show you actually the next one. So we actually she got placed in a coaptation splint, but if you look at this X-ray, this looks like the pattern you were talking about before, right? That shaft extension, the ones that don't go on to heal very well, or is that a little bit different?
No, those are kind of proximal third with a long oblique laterally, and the deltoid tuberosity on the distal.
Yeah, those don't heal.
Okay, so you think that this is going to do something? This will heal well then, this shaft component.
Yeah, I mean, I think it would be in the 80 to 85% range. Would it be, if it were isolated and treated in a brace?
Okay, so this lady doesn't live in Seattle. She lives in Menlo Park. What are you going to do when she comes to your clinic to see you?
Yeah, this is pretty significant, so this is, I think, pretty clearly a very small head fragment. She's 90, she's 79. Go back to the.
Do they make a 12-hole cage plate or no?
Yeah, so again, this is actually, this medial extension of this fracture line is even more proximal than the last one, just rendering that head a little smaller than the last one. So I think it's the same issues. Definitely would be able to figure out ways to support this head once reduced and to secure the tuberosities once reduced. The combo injury, would be probably an orthogonal plate for me.
Yep.
Or maybe lag and just extend a long plate. And so, but that'd be one option. And then, obviously an arthroplasty would be reasonable for this severe displaced pseudo dislocation in a 79-year-old. And then what to do with her diaphyseal fracture then. I guess I don't know if it would be worth a long stem reverse versus like lag and plate, or reverse and then lag and plate with proximal screws around the stem.
Yeah, I think those are really good options. Milton, are you fix or replace or both?
I mean, I'm looking at it, listening to how she sounds, looking at the injury. I think I'm leaning in the fixation, or in the reverse for the proximal humerus. But I think the biggest thing is figuring out what kind of stem am I going to use? Am I going to cement it so I have a little bit more space in the stem so I can get a plate around it for the humeral shaft, or am I going to try to run my, am I going to try to put a long stem reverse in for her, which I think, even still you have to reduce and kind of fix the humeral shaft. I probably would lean towards a shorter stem reverse, and then long plate to bridge, or not bridge, but lag screws and direct for the humeral shaft component.
Okay, Dave Bray, I know you maybe not replacing these, but what would you do fixation wise?
Well, geez, why don't you guys just throw out the whole top half of the humerus?
It's a lot easier that way.
I would compression plate that spiral. I would do an open reduction and clamps and lag screws and fix that, and then combine that with whatever arthroplasty is the best one for that fracture. Sounds like a reverse. If I don't know the machinations of the reverse and the stem and the cement and how that goes, but I'd put a plate on that and then make it work with a reverse.
All right. Well, considering I trained here, but also trained in shoulder and elbow, I kind of combined the best of both worlds. So to Milton's point, I think reducing the fracture first is the most important thing for the humeral shaft, because you cannot do a reverse in the humeral shaft if it's broken. So that's the first thing I did, reduced it, and then put this unicortical plate on to hold that reduction in compression, and then did a long stem humeral component to help stabilize that fracture, and then just did a standard reverse. And so obviously there's different options. I think nowadays I probably would have changed this for a lag screw with plate for the humeral shaft, and then do a small mini stem in the proximal component to do the reverse.
That was a question I had. Have you had good experience using those stubbies in fracture situations? I mean, I'm pretty comfortable using a stubby in a primary reverse, but
I think if there are fractures like this where it's one large, like almost like a segmental fracture, where there's a good amount of bone proximally, then I totally would feel comfortable. In those comminuted ones, like let's say the one that Mike showed earlier, but that needed a reverse, then I think a long stem would probably be more secure for me. So here's that patient at 3 months. At 3 months, she already has 120, 115 degrees of forward elevation, and she was very happy. So whether or not this is the right option for her, I don't know. I think nowadays, like I said, I would probably do a long plate combined with a short stem with, absolute stability of the fracture. But I think both are options. All right, Mike, why don't you take us home with this last case?
All right, last one. So 47-year-old male, non-smoker, right hand dominant, tripped and fell, isolated. Milton, what do you think? Proffer study, no benefit to surgery.
Don't even. Looking at this injury already, he's already in varus. And, I don't pay too much attention.
He's already in varus. So is varus a risk factor for anything? Is that what you're implying?
Yeah, I think varus is a risk factor for failure. I think you're going to have further displacement from the rotator cuff muscles. You're going to have some superior migration because of the deltoid. You're going to have the shaft medialize a little bit. And so I expect this to kind of get worse before it gets better. And, he's 47 years old, so a young guy. Even though, people always say right hand dominant, but, I use both my hands every day, all day long. So, it doesn't really impact it. Maybe it impacts in older, demented patients, but in young, active people, I think it doesn't really impact my decision-making that much.
Okay.
And so I'd have the conversation with him and explain to him that there's a possibility he would heal like this, but, given where his tuberosity is, you can see his grade is already higher than his humeral head, so he's more likely to have impingement. I explained to him that if he does heal, he'll probably have some decreased shoulder function. And so I would recommend fixing.
All right, Jonah, any kind of rule for a trial of non-op or definitive plan of non-op here?
I think if it was 74, not 47, I'd probably offer it. But at 47, for me, I'll tell the patients, listen, this may or may not heal. I don't know, but I know that if we fix it, this to me looks like a stable 2-part. I can get you moving very quickly, and I think functionally, yes, there are complications associated with it, but I think for rehab and for getting back to function, I'll be more aggressive. I'll offer it as a treatment. It doesn't mean it's the right thing as far as the evidence goes, but I found that patients who are younger tend to be less content with waiting before moving again for the non-operative treatment.
Very good. So this was kind of interesting. So he started out being treated elsewhere, and so he went down the non-op road.
Uh-oh.
And so he comes to see me, and he's 2 months out from his injury. So we talked about treatment here. So 2 months now.
Ugh.
So what do you think? So
Yeah, I mean, like we talked about, right? So you can see that his deltoid pulled his shaft up. You can see that he's kind of been windshield wipering inside that humeral, inside the humeral component, or in the head component. And so now you're dealing with the fact that you're probably going to be a little bit short, and he has this nonunion here. He almost has pseudoarthrosis.
Exactly. So I think that's kind of the, important, I think, pattern recognition to show this at this point, right? So, we don't need to wait for 6 months to diagnose an nonunion. And this is the look of this kind of corticated undersurface of the humeral head, where this is, when the motion is this persistent that it forms this look of an X-ray. To my mind, this doesn't really have a chance to heal on its own now. This has kind of missed that window. Mm-hmm. So we recommended surgery, and he was, I think, from Santa Cruz area, and he went back, and like a week later got a DDT for reasons that weren't clear, but it got postponed. And so he comes back for just like more discussion. You can flip forward. Now he's 4 months. So go forward one more time. And so now, what do we do here? So 47, Jonah, 47 years old.
I think waiting right now serves no purpose. Like I said, I would have probably offered surgery on day one. So I think for sure surgery. And then to me, this is open reduction to fixation. with some form of bone graft, depending on if I think I would get a CT to see that inferior neck there, but I think you know, you got to keep the CT people in with jobs, you know, to get them moving. So I think I would get a CT just to see the head, to see if I needed some sort of structural allograft to help, you know, either with a metal type cage, like you said, or a fibula. But the other thing is, you know, to know whether or not I need to go and get some autograft. And so, yeah, I would take them back, operate. You know, distracting this is what's a little bit difficult at first. So getting it back out to length. If you look in that Hard Review Tips and Tricks book that you co-edited, there's that trick with Dr. Henley putting a distractor in through the shoulder. I don't know that that's ever really been done and worked, but I think going and freeing that that fracture up, making sure you clean it all out, and then really distracting it. So I'll often use a laminar spreader in there and really kind of work it continuously, get in to the right segment, and then put bone graft, and then put a plate, a laterally placed plate, like a proximal humerus plate, and compress it as much as possible.
All right. Yeah, good.
Can I make a comment?
Please.
This might be one that you want to take out. I don't know if you have this tracing paper and a pencil, and draw it out and see really if there's going to be where the defect is, if there is one. And one of the ways that you can correct that is if you do some sort of small, like laterally based closing wedge osteotomy or something like that to improve your alignment, get good quality bone edges, or to at least appreciate if you have a defect, the size of it, where it is, and where you're going to graft it. This might be one that you just might want to draw out and just kind of envision it first, so that you have a bit of a strategy for this one.
Yeah, I like it. I think it's a good point. So I found these surgical neck nonunions invariably have a defect, often medially, and you can see here, you can even, you know, prior to tracing and realigning, you can imagine the defect. So I guess first point is, you know, complex tuberosity involving multi-part proximal humeral nonunions have just historically, anyway, in the literature, done relatively poorly with revision. But these, which aren't that uncommon, surgical neck two-part non-unions are really predictable to treat. So I think it's just an important point for, like, non-union knee-jerk arthroplasty is typically not a great solution. And so you can go. So this is this is probably the case I most often use. You can go forward, a fibular allograft. So here's it going in. We talked about it last time. So on the left, you can see the vessel loop, and that vessel loop is around the axillary nerve. So you see where it is relative to the fluoro, and then there's a little retractor here, retracting out of the way. So just by displacing the shaft laterally, we just have this kind of DHS drill in here, breaking up the cap of fibrous tissue. So we kind of clear it out and then just realign using an elevator to get it out of varus. And we're trying to look at reestablishing the calcar just as we would in an acute fracture. And you can go forward. And then we redisplace it. And oh yeah, I guess we talked about this last time. Just how the kind of fibula goes in through the lateral side, just goes kind of right down into between the tuberosities, into the shaft that's lateralized. And then kind of tamp it medially to buttress the medial defect while kind of retaining the varus valgus with sutures typically. And then I'll put a plate on and wire it, and then check an axillary and make sure that the sagittal plane is correct. And the fibula is correct too. If it's kind of retrograded too far, it can go anteriorly or posteriorly without realizing it. So you just want to kind of have it centered and making sure it's doing what you're doing mechanically. But once you get that in place, you know, it's hard to miss it now with screws. And then this is really just a rock stable construct. And I haven't had one of these go on to fail. Not that I've done them a ton, but seems to be, again, just rock stable construct when you really box in, you build a box with this medial side, and this thing goes on to heal pretty quickly. And I think next one is, 5 months. So he's doing well. He's bridged anteriorly.
So I think one that looks great. I 100% agree with you, Mike. Like, to me, these two parts don't need arthroplasty. I see a lot of my shoulder and elbow colleagues do arthroplasty for these, and I think these reliably respond to fixation and augmentation with bone, either bone graft or some type of structural bone graft. I think Dr. Dunbar brings up a good point. So I've done a few of these where the true transverse, where I've compressed them using an ATD, so an articulated tensioning device. And I actually had one of them, I had an older lady fall and break distal through the ATD hole. So I wonder if anybody else has had an issue with the ATD, or if anybody else uses the ATD. I know Dr. Beret likes to use it a lot in the peritrochanteric non-unions, but I was wondering in the proximal humerus if anybody had to use it or does use it regularly.
Yeah, I have a few times. I don't routinely, but I mean, it's pretty much always a good idea to compress a non-union. So anytime it's feasible with the bone quality and the proximal, you need to have a proximal anchor point that's strong enough to pull against. But with, if you have that, then it really helps the fracture to heal.
Milton, any experience?
Not using the ATD up there, but I generally will try to get compression either kind of coming from a clamp or something else in that situation, or indirectly reducing them. But with the non-unions, I try to get more. I try to use a clamp along the lateral side to get most of my compression, and then to make sure I'm locking the fibula in with my calcar screws and with everything else after that.
Yeah, I totally agree. So one other point that Dr. Moon brought up is, you could probably use a Verbruch clamp too, without using if you didn't want to put in a large, large screw hole for the ATD, but those are different options. All right, so take home for the case number 8 is, non-operative treatment, while the newer literature will have you believe that that's the only thing that we need to do for these fractures. It doesn't always work in recognizing those varus deforming patterns early, and identifying, the delayed non-unions or the delayed unions or the non-unions before they happen, and deciding when to act sometimes can be difficult, right? Should you do it at 2 months or 3, definition of non-union is not before 3 months, or, progressive 3 different x-rays for depending on the bone. So sometimes knowing that these are going to go on to fail, just like we talked about in the humeral shaft at 6 weeks, pretty reliably, that they're not going to go on to heal if they're still moving. And so, pulling the trigger, and then when you're actually going to do it, thinking about, restoring anatomy, increasing stability, and just like Mike said, really compressing non-unions. And I think I learned this from Dr. Beret in fellowship, but non-unions love compression. So the more you can do it, the better it is, whether that's through clamps or other things, and then adding some biology and stability as needed. Does anybody else have anything to add?
Awesome. No, really good.
All right, so we're just a little bit over time, but it looks like we still had a lot of people here. So it seems like there's interest. So as long as everybody is still interested, I think we'll plan on keep on doing this at least for the next few weeks. Next week, I think we're going to talk about humeral shaft fractures. So we started a little bit today. We'll work our way down, and then go down to the elbow, and we'll try to get other faculty involved and everybody from the different universities. And so I'd like to thank everybody for coming. Really appreciate it. And thanks, guys.
Yeah, thank you, Jonah. Great job again. Thanks, Milton. Awesome.
All right, Mike. Good
Thanks,
talk.
guys.
Yeah, see you guys.